welcome to tonight's Ask Your Doctor question and answer session. I'm Dr. Alan Thornhill. It's my pleasure to be hosting this evening. I've been working in IVF or reproductive medicine for the past 25 years in a variety of roles: research, clinical embryologist, clinic manager, industry, the UK's fertility regulator, and most recently as a fertility coach, which is why I'm really interested in tonight's topic, and I hope you will be too, because it's a really interesting, exciting, and important topic. It's also one of the most common reasons why people seek me out as a fertility coach. So tonight's all about IVF and fertility treatment when using your own eggs for women over 40. It says chances in the title, but I think we're also going to cover options, and I'm hoping you're going to ask some questions on that too. It's a fact that it's harder to achieve and sustain pregnancy as women get older. And in many countries, more and more women, for a variety of reasons, are beginning or continuing their fertility journey in their late 30s and into their 40s. While egg donation is an option for some, many women prefer to use their own eggs if possible, and may want to consider all opportunities and explore all options before taking a different route. So I'm very excited to be joined by an excellent panel of doctors this evening. It's my first time meeting them, and it's lovely to meet them. So let me just pull up their names. Dr. Harry Karpouzis, who's scientific director and founder of Pelagos IVF in Athens, Greece. Dr. Natalia Szlarb, who's a gynaecologist and fertility specialist at Vistahermosa in Alicante in Spain. And Dr. Nisa Félix, who's a fertility specialist at Ferticentro in Coimbra in Portugal. So before we begin, I've just got to give you a few housekeeping rules to help the event go smoothly and for you to get the most out of the evening. So let's call them rules. There's a few rules for you. If you want to ask a question, the best place to put it is in the Q&A box, not in the comments, because there's a lot of comments coming in. It's pretty hard to find the questions. So put them in the Q&A box, and I'll be handling those questions as they come in. We've got some questions already that we think are important for you, but if we get tons of questions, we'll always prioritize yours. We may not be able to get to all of them because of time, and we want to provide the best value in the answers. So if we don't get to all of them, you will have an opportunity to send your question directly to the doctor or the clinic where it's most relevant. All of you are anonymized, so we don't know who's asking the question. Just letters come up. The session is going to be recorded. And then what else do I need to say to you? Yes, so I'm going to be asking the doctors, if you write the question to a specific doctor, we'll have that person answer first, but we'll give the other doctors a chance to respond if they've got something additional to add. So this is my comment to the doctors here. I'm sure you will hear stuff and think, yeah, I would have said that. So please don't repeat it. Say things useful on top. Otherwise, we're just going to get a lot of repetition. So I think it's time to begin. And the first question is going to go to Dr. Harry. And is it possible to improve egg quality and quantity after the age of 40 for a woman? Over to you.
Okay. First of all, nice to meet you and nice to meet everyone. Interesting question, very interesting subject generally. Two different things. The first thing is the quantity, the second thing is the quality. There is no magic way of miraculously improving the quality. The quality depends usually in one factor, and this factor is age. Of course, there is some data behind things that might help, and there are some things that women can't do before they proceed in IVF or even before they try spontaneously to get pregnant. Folic acid is something that we all know about. Vitamin D and the levels of the vitamin D to be proper is something, again, that we need to know about. Coenzyme Q10 has some good data behind it, and it is important. There are many multivitamins that include different aspects like melatonin, like coenzyme Q10 together. All these things might help before an IVF without really miraculously causing a very big improvement in the quality of the eggs. Generally, a healthy lifestyle, diet, all these things, sleep, even yoga, acupuncture, are things that you can try to improve a bit your chances. Now, regarding the quantity depends on the number of follicles and the AMH, basically. So in one IVF, we cannot get more eggs than the amount of follicles that we have. Some data behind the DHCA, it's not completely proven. In some of the cases, we might use it in relevant doses. PRP, that we might talk later, is an option that, according to some data, might help in improving the follicular recruitment and get you a bit of more eggs. These are things that you can try before the IVF, and of course, to choose a personalized and the right protocol for you. As a general rule, the number of eggs that you get depends on how many follicles you have, and you cannot stimulate follicles that do not exist in one go.
Okay. So, Dr. Natalia, would you like to add anything to that? And maybe either anything additional, or maybe comment on how much of these supplements people should consider, because that's something I come across, is people saying, oh, I'm going to take supplements, and they go, I'm on double the dose, so that should be doubly good, which always worries me.
Yeah, it worries me too. I think that, Harry already mentioned almost all miraculous medication available. The thing that, we could add probably, there are some studies published regarding the low dose of growth hormone sub-Q injections and testosterone gels before, an IVF cycle. In the US medicine, we are, focused on DHEA CoQ10, and the dose, according to FDA, is standardized. So, you cannot double the dose because it could be toxic for you. So basically, it's probably it, and the quantity of eggs depends on antral follicle count and AMH. So all the patients, before they are getting treated here in Vistahermosa, are assessed with their ultrasound. And as Harry said, there are no miracle follicles that could appear there, which are not there. So basically, the antral follicle count and the AMH will tell us how many eggs we are going to get, and we have to adjust the dose of medication to this ovarian reserve of this patient that we have. But before we perform IVF cycle, basically the DHEA CoQ10, high dose vitamins, folic acid, testosterone gel, sub-Q, super low dose of growth hormones in the injection. There's no more magic, as far as I know. I wish there was.
Okay, thank you very much for fleshing that out a little. Dr. Nisa, would you want to add anything at all? And you can obviously use experience and stories that you might have to kind of color it a little.
I would like, so first of all, good night to everybody. Thank you to be here with you. Unfortunately, I can't add anything else. I would like it to be possible to do that magic to improve quality and quantity, only using some miracle medicine. But unfortunately, for what we know at this point, I think my colleagues just summarized all the best options that we have. And just so women are informed, they are not miracles, and they are based on few data, few studies. So at this point, I think we have to use them carefully and case to case, and always explaining that at this point, none of these strategies shown really that they will work. But it's what we have, so we should always discuss them with our patients and use them case to case.
Okay, thank you. Well, I think it's really important. So if I were to sort of summarize the theme here, is there's lots of things to try. Nothing is miraculous. I think that's really important, because it's kind of easy to reach out and try and hope for something miraculous. We might come back to it, because I see some questions in the Q&A, which is great. Keep them coming. We might come back to, if you were to prioritize what you should do first before seeking treatment, for example, or before you actually engage in a treatment cycle, what would you do? Because that's a question people often ask me before they're actually involved in treatment. Is there anything they can do? And often the men ask that too. But what I'm going to do right now is I've just flicked through the questions, and I'm going to pick the ones that are very relevant to this question so we can kind of answer them at the right time. I think I understand this question to mean, do we prioritize AMH or number of follicles seen or antral follicle count? So I'm just going to put that one on. And Dr. Nisa, could you answer this one, please?
Yes, okay, of course. So when we study a couple, one of our main goals, it's actually always the ovarian reserve, because in IVF we depend basically on two things, quantity and quality. The quality, we already told that it's based on the main factor, that is age, and the quantity, we need to access that based on two factors: what we see on ultrasound, and it's the antral follicle count, how many follicles we can see in an early phase of the cycle in each ovary, and then the quantity accessed by a blood test, that it's AMH, that gives us a number, and that number reflects the ovarian reserve of a lady. Of course, we have to take in account the two factors, because in my experience, and that's a very personal opinion, I prefer to base my opinion in the antral follicle count. Of course, I always take into account the AMH, but what I see in ultrasound usually reflects during the cycle. But like I already told, we're taking it into account the two factors, and that will help us to counsel and to advise that couple about the expected success rate of that IVF treatment, and of course also to guide us into what type of protocol and what type of dosage of gonadotropins we will use. So I would say both of them are important, and both of them will guide us through the treatment to decide what's best for that couple.
Okay, thank you. Dr. Natalia, would you like to add anything to that? And I suppose what I'm looking for is a sort of concise version of which do you think is most important? It's okay to say both. And can you say anything about because this comes up a lot with patients, I'm sure you're all very familiar with this, the kind of mismatch between an antral follicle count, a scan where you say how many follicles of a certain size are present, or the AMH, and then the patient ends up with maybe very few eggs and says, hold on, I had this big number at the beginning and now I've got this small number now, which is a very common thing that I experience when I'm talking to people.
It's a very good point, that, some people expect a different outcome when they're after egg retrieval, and this outcome does not fit in any way to the ovarian reserve at the beginning of the treatment. So, ovarian reserve are 3 A's, and there's no more magic here: H, AMH, antral follicle count. And I agree with Nisa that we have to take into consideration all 3 factors, because sometimes we see one follicle more and the AMH is low. And from my experience, some colleagues measure antral follicle in a different way. So some colleagues, the antral follicle, which they have sometimes an amazing ultrasound machines, they see even follicles that are 3 millimeters, and they say they're antral follicles. And some colleagues measure follicles which are 6, and these are antral follicles. So some colleagues over measure the follicles. Basically, we should count the follicles which are 6 millimeters, and everything less than 6 probably will not respond. So this is why, some people say, oh my God, somebody has, some doctor, some sonographer at the beginning of the cycle saw 12 follicles, antral follicles, and I just have 4 eggs. And then the factor that brings us really down to earth is an AMH. AMH, in a very cold scientific way, will tell us how many eggs we do expect from you. So instead of giving a patient this kind of like over expectations and being very optimistic, measuring their antral follicle count, let's maybe, keep it to ourselves, especially when, we have young colleagues that are starting the journey in reproductive medicine, and let's focus more on the AMH, because this value will never disappoint us. From the other hand, working, already 12 years here in Spain, and coming from the US, in the US, before any IVF cycle, we were putting patients on birth control pills. And these birth control pills were kind of shrinking a number and the measurement, the diameter of antral follicles. And then these people with low AMH pre-treated with birth control pills usually had a worse outcome. So, when you have this patients with advanced maternal age, and you have to be like very careful how you treat them. You have to really, when you decide which dose of hormones you're going to give them, probably it's wiser, and in my experience, and this is something that I learned in Spain, is better probably not to pre-treat them with birth control pills, not to downsize the follicles, not to diminish the number of antral follicles. So as Harry said, the miracle antral follicles that are not there because probably we killed them with birth control pills are not going to pop out in the middle of the cycle, and they are not going to be there, okay? So with, advanced maternal age and AMH and antral follicle count, we have to be very careful. What do we say to a patient? Which dose of medication we give them, and how do we pre-treat them?
Okay, that's lovely. Thank you. That's a good segue onto the next question, which I will hand back to you, Dr. Natalia. But first, Harry, have you got anything to add to that in terms of what you would prioritize or not?
Yeah. I couldn't agree more with my colleagues. I mean, all 3 of the factors, age, AMH, and antral follicular count are important. If you ask me, though, personally, and out of my experience, what I would consider the most important is antral follicular count. We work a lot with that. I think it strongly depends. I mean, we work with very personalized protocols. The important thing in every protocol is to personalize it to its case. Natalia is very right. I mean, a pill can reduce the number of follicles, can cause it more difficult to stimulate follicles, might disappear some follicles. So you need to know when to use the pill. Sometimes in medical tourism and people coming from abroad, it might be difficult to schedule without the pill. But despite that, there are options. And if someone has a very low AMH or a low antral follicular count, it is better not to give the pill, of course. 3D machines and all this equipment, I mean, measures follicles that are in the middle of the ovary. I don't agree in that. These are not follicles. These might be primordial follicles or anything else. Follicles are follicles that we can see. We use many cases luteal start follicles as well. And the reason that we do that in poor responders is because in the second half of the cycle, sometimes you have a better follicular recruitment rather than the first, and it works very nicely many times. The dose depends on the number that you can see, and as Natalia has said as well, it depends on the size, because if you have follicles that are less than 5 millimeters, it is very difficult to stimulate them. If you want to stimulate them, the only possibility is to threshold them with a high dose of gonadotropins, If you have follicles between 5 to 10 millimeters, though, they can be stimulated with lower doses as well. And these are the follicles that you usually get. So the whole point is to explain to the patient that you cannot get more eggs than the follicles that you can see, that the size plays a role, that it is better to start on the timing of the cycle that you have the more follicles. And of course, you get some information from AMH, etc. Yeah.
Okay, thank you. So this is really good, because what we've done there is we've talked, we've strayed a little bit beyond, but we've talked about what you can do before you go into a cycle, before you have stimulation. And then the next question is about, should we do something different in terms of stimulation? And I know Dr. Natalia started talking about it, so maybe you can continue. And if we can keep it kind of, I know it's complex, but if we can keep it a little bit simplified so that, you know, and I realize every patient is different, but so that we can understand, is it a case of if you have a low reserve, you just give more drug, or do you do different things? I think that's the kind of message we want to try and convey. So the question specifically, let me go to the actual question. It's, how does age impact the response to ovarian stimulation? And if you can restrict it to, you know, late 30s and over 40s, because that's what we're focusing on today, you know, what are you going to do differently about stimulation in those older age groups? Dr. Natalia, sorry.
Okay, good. So in the clinic where I work, we adjust the dose not only to patient antral follicle count, but to AMH. Okay, so I know that with the patient with AMH under 2, and these are the patients at the age of 38, 42, which is AMH between 0.3, 0.6 to 1.5 nanogram per milliliter. It's very hard to hyperstimulate them. So the other thing is low AMH and high dose medication. My answer is no, because this kind of ovaries quite often get blocked through high dose of medication. Spain is famous for this type of cycle called embryo banking, where we, in patients with a low ovarian reserve, we perform one cycle with a middle dose protocol. Middle dose in Europe is 250 units. And we see how many eggs and embryos do we get, and we test them genetically. We perform PGDA for aneuploidy, and 2-3 months later, we perform another cycle with a low dose protocol. Low dose in Europe is between 75 and 150. Don't go 75 units with patients 38, 40, because it's going to be kind of insemination, not a low dose protocol. So you have to give like at least 150 units and see how many eggs and which quality of embryos you're going to get, and PGDA them, because I came to this country to learn what PGDA is all about. And I've seen a lot of people, a lot of patients in advanced maternal age generating even beautiful embryos, you know, AB quality. Even in embryo banking, we can go up to 6 embryos, and only 1 or 2 are genetically normal. So when we talk about, you know, which protocol, it has to be adjusted to patient age and AMH. And then the strategy to develop, to grow embryos to day 5 and to select the genetically normal ones, this will be an approach that we would use in Alicante.
Okay, thank you. We have a question later on PGDA, so we will be going into more detail on that. So if we can, so if we can sort of, you know, focus on the stimulation part. I realize that it's linked to what your ultimate outcome is, but from a patient's perspective, as you know, their goal isn't to necessarily get embryos to test. Their goal is to have an embryo that potentially will be transferred. It's just, that's the means to the end. Dr. Nisa, could you add anything to that, please? And again, use specific protocol types in your clinic if appropriate.
Oh, okay. But I think it would be good as well just to go a little bit back in time and just to answer these questions so couples and ladies could understand how really age impact the response to ovarian stimulation, just to understand that point and then continue that conversation.
Please go ahead.
It's like we have been talking, we depend on quantity and quality, and age unfortunately decreases them both. Quantity, because we know that we are born with a certain pool of antral follicle counts, and when we reach 40 years old, unfortunately, that pool, we will only have around 3% of that pool with 40 or more years. So that's why our ovarian reserve decreases that much with time. And then the quality, that's more about biochemical and biochemistry processes. I will not get into molecular things, but just to understand that the quality, the competence of the oocyte, and then the embryo that is generated from that oocyte also decreases with age, because we know that that quality will depend on the nuclear, on the chromosomes of that oocyte. And that's why with age, women experience more difficult to get pregnant, and that's why we have infertility, more chances of getting miscarriages, more risk of a fetus, a baby with chromosomal anomalies. And that's why we tell them that age really interferes in the quality and the quantity. And that is to say that age will interfere in the response to the ovarian stimulation. As my colleague already told, we have to adapt the protocols to each lady, to each couple. Of course, we can have more experience with one gonadotropin or with another, with a certain dosage or another dosage. That will really depend of our goal. But like Natalia told us, we need to adjust the protocol, and our main goal is to get the more quantity of eggs as possible, and the more eggs that have more quality as possible, because our main goal is to generate embryos, and as we know, when age increases, the quality of those embryos will be again less, and most of those embryos will be not chromosomal normal. So that's why, especially over 40, we advise couples to do PGTA, and then we'll talk a little bit more about that, just to so we can differentiate the embryos that are genetically not normal from those that are normal. So we can only transfer those embryos that are normal. So I think that's it. I think we have to explain couples why after 40 suddenly our expectation, our success rates decreases that much, and that's because really age impacts on the quantity and the quality of oocytes, and then of the success of the ovarian stimulation.
Thank you. And thanks for taking us back a little bit in terms of the explanations, because we are throwing a lot of acronyms around. In fact, one of the questions in the chat is what is AMH? Do you want to give a 2-sentence explanation of what is AMH?
So AMH is, just to be as simple as possible, okay? It's something that we can dosage in the blood. So it's something that is produced from the antral follicle, the antral follicles, so that we can measure it. So we have a number, and that specific number will tell us what we can expect that will happen in that cycle, how that lady will respond to the medicine. Of course, like my colleagues already told, sometimes we have surprises. Sometimes ladies that have exactly the same value of AMH just respond differently with the same protocol and the same dosage. And that's because, like I already said, I think AMH is very important, but we have to take into account the number of antral follicles that we see in that specific cycle. And that's why sometimes we have differences when we use exactly the same protocol for exactly almost the same AMH values.
Okay, and drum roll, I don't know if you said what AMH actually stands for. It doesn't matter in a way because it's just an acronym we use, but just so people know what that is. I know what it is, but do you want to say what it is? AMH stands for? Anti-Mullerian hormone. Okay, anti-Mullerian hormone. I'm saying that so that because there are a lot of letters and acronyms that get thrown around, and it's important if you're talking to a doctor or anybody and they say, okay, what's your anti-Mullerian hormone level? And you might think, yes, I only know it as AMH.
Right.
Okay, so we've answered that one. So I'm just going to do done answering. And Dr. Harry, if you wouldn't mind just giving us your thoughts on the age impact on ovarian stimulation. We're going to move on to low reserve specifically in a second, but if you can just talk about age.
Okay, I mean, age affects the quality. This is something that we know for sure. If you're asking me about how age affects ovarian stimulation, I mean, it does affect, because, for example, if we compare a woman that is 41 and a woman that is 35 and have the same equal number of follicles and equal number of AMH, most probably the woman that is 41 will do worse in the ovarian stimulation despite that, in comparison to the woman that is 35, because older women do have resistance in the FSH that stimulates the follicles, okay? So the age is an important factor that needs to be taken into consideration when we choose the protocol and the dose that we need to adjust for each woman. Now, if you are asking me what is the best protocol, I mean, as a general rule, very, very simple. I mean, if someone has more than 3 follicles, might be a benefit in getting more eggs with high dose of medication. But if someone has less than 3 follicles, even if we give more medication, she will just pay for more medication, but she will not get more eggs. So women that have a small number of follicles, less than 3, the best thing that they have to do is to go on smaller doses, because they can get this number of eggs without really paying more money and getting themselves into more injections. And in cases like that, we know now we vitrify, we have the weapon of vitrification. So we are not interested in the implantation window. We are not interested in things like hyperstimulation and things like that. So they can bank. They should know that if they have only 2 or 3 follicles, they just get 2 or 3 eggs, and that's their target in one go. And statistically, the more eggs you get, and there is clear evidence on that, the more you increase statistically your chances. You might be very lucky and you get 1 egg and you are 41 years old and you get pregnant. Okay, you are lucky. But statistically, if you have more eggs, you have more chances of one of these eggs being chromosomically normal. So if you cannot achieve this in one go, you need to try more and more and more so that you can get more number and hope of one of them to be chromosomically normal. If you will PGTA them or not, I'm a very big fan of PGTA generally. If you can afford it, you do it, of course. And if you find a chromosomically normal embryo, then you don't need to bank more embryos because your chances will be about 70%. Yeah. So as a general rule, I mean, now regarding the protocol, okay, there are many different protocols. The answer and what I like to say to people is that the best protocol is a personalized protocol. And second, keep it simple. The best protocol is always an antagonist sort protocol. But you need to perfectionate this protocol. You need to personalize it and measure the blood test, the LH, the estradiol, so that you can make sure that all the follicles will reach the same size at the same stage, okay? The more you can, sometimes it is impossible. And in the end, if it doesn't work, then yes, there are innovative protocols. We use double stimulation protocols. We use letrozole and stop agonist protocols. Many weapons in our hands, but first, keep it simple, and second, personalize.
Okay, thank you. I'm hearing PGTA coming up a lot, so why don't we jump to that, because there's quite a few questions on that. We will answer the other questions, but I'm just going to go to the PGTA for now, because I think we've We've sort of covered some of the stimulation. There's obviously an overlap between age and diminished ovarian reserve. They don't necessarily go together, but they often do. So let's talk about PGTA. Let's go to Dr. Nisa. Do you want to, using what you said last time about stimulation and ovarian reserve, do you want to very briefly explain what it is as simply as possible, because it doesn't really need to be complex?
Yes.
And then talk about how you would use it, if at all, in this age group, not generally in this age group, because it is a little bit different in this age group.
Yes. Okay, very well. So what is PGTA? So again, like AMH, PGTA is pre-implantatory genetic test that we use, like I already said, to distinguish between chromosomal normal embryos and abnormal embryos. So when we stimulate the ovary, our main goal is to obtain as many eggs as we can. Then we do the oocyte retrieval, and those oocytes that are mature, then they will be fertilized by spermatozoa with a simple IVF or an ICSI. Then, especially here in Ferticentro, we use a long culture of the embryos. We wait for them to reach the blastocyst stage at day 5 or day 6. And those embryos that reach the blastocyst stage and have quality, then they will be biopsied. The biopsy is to remove some cells, some couple of cells, that will then send to a lab to be analyzed. And that cell, it's a sample of the genetic of that embryo, and that sample will tell us if that specific embryo has all the chromosomes, if the chromosomes are normal, and that is to say that we have an euploid embryo, or if not, we have an aneuploid embryo, a non-chromosomal normal embryo. Those embryos that are not normal will be then destroyed, and those embryos that are chromosomal normal, we will keep them, and then we will do transfers because that are really the embryos that will give us chances of a normal pregnancy. We know that embryos that are not chromosomal normal, they will not give chances of a good pregnancy, or at least a miscarriage. So why we use PGTA, and why I think PGTA special in this age group is so important? Because we don't want to waste time and money. So we don't want to transfer embryos that give us no chances of achieving a good pregnancy. And if we use PGTA, we will then lower the rate of negative pregnancy tests, lower the rate of miscarriages, lower the incidence of fetus with chromosomal malformations, lower the time between transfers that are not a positive one. And in this specific age group, studies shows us that PGTA also increases the live birth rate in this specific group. So I really think it's a very good option when couples can achieve it to do PGTA, especially in this age group.
Okay, thank you. I feel like it's right for me to sort of disclose my interest in PGTA, because I've been involved in it from a scientific and an industry point of view for a long time. This is not me, what I'm about to say is not me recommending it, it's just making an important point about this age group. So I've sat in consultations with doctors and patients where the doctor said to the patient, oh, you don't have lots of embryos, so we shouldn't do PGTA. But for the reasons that Dr. Nisa said, and the concept that if you don't want to have a miscarriage and you want to find out what the cause of you failing might be, it's worth testing the embryo. That's a different reason, it's a different rationale than selecting the best embryo from a cohort. So I just wanted to make that clear, because that misconception comes up a lot when I speak to patients and even when I speak to doctors. So it's not me saying you should do it. It's me saying you need to understand why it's being recommended or not being recommended, and it needs to be a clear explanation. I've put up a question here because I'm sure, Dr. Natalia, you're going to say something about PGTA, because you already said that you're involved with it. and that's one of the reasons you came to learn about it in Spain, where I know a lot of it goes on. But I thought it'd be worth also answering this question while you talk about PGTA. A person here has asked, I'm 42, just found out yesterday that my 3 blastocysts had NGS, next generation sequencing, the most advanced type of testing available today, but they're all found to be abnormal or complex abnormal, which generally means, as Dr. Nisa said, generally means they're not likely, they're, in fact, extremely unlikely to produce a healthy live birth. Therefore, they're either discarded or they're certainly not transferred. So this lady's asking, should I do this? Should I, go through the whole procedure again after at age 42? So in your answer, Dr. Natalia, can you cover that one as well, please?
Mm-hmm. Sure. One of the best, studies published regarding to the euploidy rate means number of genetically normal embryos in different age group. From 2015, I believe 60,000 embryos were genetically examined back to retrogenetic times. So we realized that at the age of 35, 50–60% of embryos which women have are genetically normal. When we talk about euploidy, number of chromosomes, between 38 and 40 years old, 30% embryos are still normal. At the age of 41, 42, about 20% of embryos are genetically normal. Statistically, 60,000 embryos. So you have to see the number of embryos that were, examined in different age groups from, people all over the world. At the age of older than 43, less than 10% of embryos are genetically normal. So you are 43. So statistically, the chance that this will happen again and we do one cycle more is very high, that you will have another unsuccessful cycle. I know that for some patients, psychologically, it's very hard, to give up on own eggs. In this kind of cases, we review the protocol that you had, and we are trying to introduce something new into your treatment. But we still, I wouldn't recommend you at the age of 42 to do another cycle to look for genetically normal embryos. If you were 40, it's a different ballgame, because then we know that 20% of embryos still have a chance to be genetically normal, euploid. On purpose, I do not pack my answer in so much AMH, euploid, so you understand what I'm talking about. Genetically normal means euploid, okay? If you decide to do one cycle more, you have to introduce a different protocol. I agree with Harry that the best protocols are antagonist short protocols, but the dose of medication has to be adjusted to your AMH. So if you had a high dose protocol with 300 units of recombined FSH/LH, why don't we give you a middle dose or a low dose, 150 this time, to maybe gain a quality over quantity? But as I say, statistically, 10% of your embryos are good. So if you are not ready to move on and discuss an egg donation, which is the final step in the infertility treatment, consider another protocol. We would do probably something called embryo banking. So, we do 2 cycles and we gather embryos and send all of them through genetical testing to increase your chances. So this will be my strategy to your case. I'm terribly sorry, because it's not, easy at the age of 44. You still feel young, full of power, energy, but the quality of eggs and statistics, it's what it is.
Yeah, thanks for your compassion, Dr. Natalia. Just to be clear, that lady, or that question is from a lady who's 42, and you increased her age by 2 years during the question, 43, 44. But I think the numbers you were giving for 42 were accurate, and you're right. It's a low percentage, so it's not zero, but it's a numbers game. This is all a numbers game, right? And that's the point you're trying to make. Dr. Harry, if you wouldn't mind, giving your perspective on that particular question as well, whether this lady should, or a lady in this situation should try again, and what your thoughts are on that. And then I've got another question that is a kind of follow-on from that.
Okay. For this lady, of course, we need to know the full history to know what is happening, what protocol she was on, if she could get more eggs or not. To answer the question, we cannot answer only from that. Obviously, the answer is very easy generally, that if you want to go with your best chances, try egg donation. If you are not psychologically to go to egg donation, it's completely understandable. And then, yes, I mean, you could try another cycle, but you need to be realistic about your chances, and your chances are low. Because in this age group, as Natalia said before, the chances of finding a chromosomically normal embryo, a euploid embryo, are low. And this is something that you need to know from the beginning if you decide to go to a new cycle. Now, regarding adjustments in the protocol of being able to get more eggs, I mean, the fact that you've managed, first of all, to have 3 blastocysts, I don't know what was your andral follicular count, your AMH, it's good. I mean, other women do not even have 3 blastocysts. I mean, the more you get, the more you increase the chances, but the chances remain low. So yes, most probably you will be able to do different things. Most probably, if you are not psychologically ready to go to egg donation, you can try something different. On the other hand, if you say to yourself that, okay, I want to go with my best chances, I don't care if it is egg donation, go to egg donation. Now, regarding PGTA, I'm answering about that, or no?
No, I'm going to give you another question in a second, which follows on. I just wanted to make a comment, from an embryology point of view, if you don't mind, everybody. So we talk about statistics. We talk about this. And I'm sorry to focus on this one particular question, but I'm hoping you can all get a sort of general feel for it. So, your chance of getting a euploid normal embryo as you get older diminishes. And Dr. Natalia has given you a value of 10%. That's a very, very accurate number, but in a way it doesn't matter. We're just trying to make the point that it reduces and reduces and reduces. But what I want to tell you is something a little more practical as well, not just a statistic. To even have that result, and this is what Dr. Harry just said, you're lucky to get 3 blastocysts, you need to have got a blastocyst. That's not a guarantee on every cycle. You also need to get a blastocyst that's good enough to biopsy. That's not a guarantee. You also need to get a test result from that biopsy blastocyst. That's not a guarantee. So to even get that percentage, you have to have jumped over all those hurdles. So those chances are getting smaller all the time with increasing age. And other factors. So it is quite difficult, but you've been given some options there of things you can do if you're not ready to take a different route. So thanks for that. I'm just going to go to this next question because I think it's a good segue on from that one. So this is now a patient who has got one good quality embryo, but it's got an aneuploid result, and we maybe can think a little bit more about what that actually means, that aneuploid result. And there has been research recently saying that some embryos can self-correct. So some of these chromosome abnormalities can effectively disappear, meaning more cells that are normal grow in their place. That's the easiest way to consider it. So you can end up with potentially a normal fetus. Because let's be clear, if you have all abnormal cells, and you always have abnormal cells, you cannot have a normal, healthy live birth. That's the reality. So when the result is aneuploid, I think actually most of the research is actually mosaic. So there's some cells within that embryo are normal and some are abnormal. But when we take a biopsy, we don't really know the extent of that mosaicism. So let's go with that question anyway and say, should this patient consider transferring it? I've also got something to say about whether they can or not in the UK. That's just from my regulation background. But let's go with what would be your advice on whether they should transfer that embryo?
Okay, listen, this is a very difficult question. This is a very tricky question. And this is something actually that needs to be explained very nicely because, as far as it regards my experience, people are coming from all over the world. Every unit grades the embryos and the mosaicism rate with different standards. It needs to be very clear. It is recommended by the guidelines, but it is not always used. So when you get a result, you need to know exactly what it means a euploid, what it means an aneuploid, and what it means a mosaic.
Exactly.
And then usually when we say aneuploid, it means a mosaicism rate of more than 80%, I mean, at least with us. And when it is aneuploid, it's aneuploid. It has close to 0 chances to get implanted. So you shouldn't transfer it, but you need to make sure that this is the case. When we say euploid, even euploid embryos sometimes do have a mosaicism, and we usually grade as euploids embryos that has mosaicism less than 20%. But there, the chances of getting implanted are very, very high. And then we have a middle category, which is between 20 to 80%. And even this category is is further divided in low mosaicism 20 to 50 and high mosaicism 50 to 80. Even after that, okay, even if you drop in this category, you need to know that when we take a biopsy, we take a biopsy from the trophectoderm, which is the outside part of the embryo, which actually is the part that creates the placenta. But what later creates the embryo itself is the inner mass, okay, which usually we don't take it with a biopsy. It is not always the case that the biopsy that we take from the trophectoderm corresponds with what is happening in the inner mass. So when it comes mosaic, there is a possibility of the inner mass to be mosaic or to be normal, euploid, or to be aneuploid. So you need to know that sometimes the decision between the 20 to 80% mosaicism rate, if you transfer it or not, it needs to be a very well documented, first of all, documentation in the PGTA, and second, you need to have genetic advice if you drop in this category, because it doesn't depend only in one factor. For example, it depends on if it is a whole chromosome or a segmented one. If it is a segmented one from a very good morphology embryo and with a low mosaicism rate, for example, okay, this is an embryo that you can transfer it and it can achieve as high as 40% chances of implantation. But if it is a whole chromosome or a complex aneuploidy like your case, and it is documented as aneuploid, and it is properly documented as aneuploid, this is an embryo that with a complex abnormality, aneuploid, which means more than 70–80% mosaicism rate, it has close to 0 chances and I wouldn't transfer it. So the answer is that it's a very complicated issue. You need to ask, you need to know what is happening, you need to know what is euploid, what is aneuploid, what is mosaic. Mosaic embryos can sometimes be transferred, but of course you first transfer your euploid ones. If you don't have a euploid and you have mosaics only, and it is your last resort embryo, you get genetic advice and you transfer it if needed. If you have an aneuploid embryo and a complex aneuploid embryo with a full chromosome abnormality, I mean, this is an embryo that you shouldn't transfer.
Okay, thank you. Yeah, that was really clear. Thank you. Dr. Nisa, could you give us a brief answer on what you would advise and what you would do in your clinic with a patient with this result? I understand there's a lot of detail that when we get these questions in, we don't have all the detail behind it, but you know, on the face of it, we've got an embryo that's been classified as aneuploid. I completely agree with Dr. Harry. Look into it in more detail, get some genetic counseling, actually speak to someone else. Certainly if you haven't got an opportunity to make another embryo, but what would you say about that? And then I want you to specifically answer if it was definitely a mosaic embryo. That's not what we've been told in this case, but I want you to cover that as well, please.
Yes, of course. I will not add any great deal of information besides what Harry already told you, but in our clinic, our results, when we get a result, we have euploid embryos, and those embryos are transferable. Then mosaic, and when we have mosaic, we have low grade or high grade. And low grade mosaic, of course, all couples have to have a genetic counseling, and it's their decisions whether to transfer or not. But we always advise that it's an embryo that continues to offer us some chances of implantation and some chances of achieving a good pregnancy. So for us, it's a transferable embryo. Of course, like Harry said, we always try to transfer first the more quality embryos as possible. So euploid embryos first, and then low-grade mosaics. And high-grade mosaics, and especially aneuploid embryos, are not to transfer, because we are pretty sure the only thing that we'll get is a negative pregnancy test, or a miscarriage, or a worst case scenario, a pregnancy that will continue, but then at the end it will have to be terminated because the fetus will be chromosomical, not normal. So to prevent all that parts that will be psychological, very harmful for that couple, and sometimes couples just, and I understand, because the journey is so long, and when they finally achieve an embryo, the only thing they want is to just believe that that embryo will work, and just to try a transfer. But let's think about the rest. Let's think about all the damage that a negative pregnancy test, a miscarriage, or worse, a pregnancy that will need to be terminated will affect that couple. So for us, it's very simple. Euploid embryos and low-grade mosaics, there are embryos that are good to transfer. High-grade and aneuploid embryos will not advise to transfer at all.
Okay, thank you. Nice and clear. Dr. Natalia, have you got anything to add on this? You can, and you, of course, feel free to say that's exactly what we do, or that's useful information, obviously.
That's exactly what we do, and thank you, my colleagues Nisa and Harry, for your answers. I still see patients in general gynecology and follow up for the pregnancy. The only thing that I could probably add is that all the patients that are transferred low mosaic embryos, and we are not sure how they're going to develop at week 10 of pregnancy, are verified with not invasive prenatal test to be sure if the fetus is genetically normal or not. Aneuploid embryos in this country cannot be transferred. It's completely illegal. And if we transfer any mosaic embryos in this clinic and in this country, they undergo, as Nisa said, genetical testing, and special lawyers' consents are prepared that patients are transferring this kind of embryos, and this is their responsibility. And we recommend not invasive prenatal testing during the pregnancy. And okay, we do not we do not recommend the the screening test with the risk evaluation. We go directly to not invasive, to see DNA of the baby at the week 10.
Okay, thank you. Just to be, because we have an audience from all over the place, all over the world, I think, and we have a panel from at least all over Europe. When you say in this country, you mean Spain?
Spain.
Yeah. Because I just want to be clear that I think the questioner who asked that question was from the UK, but I'm not sure. But if they are from the UK, you may have been told that you can't transfer an aneuploid embryo. But I used to work for the regulator. I think I'm up to date on this. You can't choose an aneuploid embryo over a normal one, but I think you can transfer it. And that's not me recommending it. That's just saying if someone says to you can't, I'm not sure that's actually true. So I think the message from this conversation is the chances of it being turning into a normal pregnancy are low, but they're not zero. And certainly it's worth finding out more about that embryo. And it's definitely something that you should do is get genetic counseling. And this is a good opportunity for me to use an example of some coaching I did with a patient who wanted to transfer a mosaic embryo. So different from what we, what the question was, but they said, should I transfer it? And I said, I can't tell you whether you should transfer it. Let's talk about it. We talked about it, and most of it came down to not having adequate genetic counseling. The doctor involved wasn't entirely clear about what the patient was asking. So it was really a clarification exercise. Clarify what you really want to do, what your risk tolerance is, what the chances are of having a good or a bad outcome are, and then proceed from there. she ended up transferring the embryo. It didn't implant, but that can be the case for lots of different reasons. But I think she got the results she wanted in terms of she got the opportunity to transfer the embryo. That's a little different from what we've just been talking about, but I just wanted to make the point. It's worth asking questions. They're your embryos, and you should know as much about them as you can of what is known. Okay, and then I'm just going to briefly answer 2 questions that came in the chat that I think we've already covered, but I don't want you to feel that we haven't covered them. I'm 45 and had 9 eggs retrieved today, so that's very good. What's the statistics at my age that I'll get a normal embryo? Well, I think Dr. Natalia already answered that, and it was probably significantly less than 10%. That's a statistic. It's not, you know, for you specifically, but the likelihood is that's going to be a low chance. And you've got 9. They may not all turn into blastocysts. They may not all get biopsied. So I just want you to manage your expectations on that. That's all. And then if I were to undergo PGT testing in 1 cycle, all embryos were found to be chromosomally abnormal. Is it possible to obtain a normal one in the next cycle? I think we've covered that as well. It's possible, but it's unlikely. Okay, so I want to move on to some, there's lots of fantastic questions in here, and some are a little bit difficult because they're very, very specific cases. But I want to sort of up level it a bit and talk about numbers and statistics in terms of success rates. So let's go to Dr. Natalia and say, how many eggs? I know this is a how long's a piece of string question. How many eggs are you expecting to get? So decent quality eggs, and maybe you want to explain the difference between follicles and an egg that we can do something with. So decent quality eggs at 40 and over, and you can do some gradations of age as well. And then please also talk about what sort of success rate you might expect. So that's, let's talk pregnancy rate and live birth rate, because they're not the same, as you know, with and without PGTA. So it's quite a lot of information there, but I think this is all useful information that people will want to know from the different doctors at the different clinics.
Okay, let's say we have somebody who is 40 years old, and this patient is coming to us with an AMH 4 or 5 and 12 antral follicles. I had not long ago a patient like this, and when you give them antagonist middle dose protocol, let's say 250 recombined FSH LH, not, you know, talking about brands. With people an AMH over 2, we expect 15 to 20 eggs. We fertilize all of them. We develop embryos to day 5, day 6. We usually expect out of 20 eggs to fertilize 16, have 6, 8, day 5 embryos. And if we do not test them genetically, we of course have to freeze them, because with these numbers, we are afraid of hyperstimulation. We don't know really what we have. And then again, you have to see the euploidy rate that applies to these 8 embryos. If I have a girl who is 35, out of 8 embryos, she has 4 genetically normal. If I have somebody between 38 and 40, she has 20-30% genetically normal ones. So out of 8, she could have 3. When I have somebody who is over 40, she could have 1 or none. So I have seen, you know, this kind of cycles in my life. Only in Spain, I worked 12 years, and Spain is very famous for PGTA cycles. I have seen people at the age of 40, 42, with the numbers that I'm, you know, naming now, having out of 20 eggs, only 1 or 2 genetically normal embryos. These embryos are very precious, because if they are embryos of you know, good quality euploid, and we put them on the right time to your lining, means sometimes you can imagine that I'm a little bit obsessive compulsive in this kind of cycles before transferring 1 or 2 last embryos that I have because of your advanced maternal age. Before I transfer them, we perform receptivity testing to see your exactly timing your implantation window, to see if there are no infections, your lactobacillus levels, to make sure that we put them on time, there is no infection, everything is great. Your chance that you will be pregnant with this kind of treatment is over 70% per transfer, okay? So it's worth doing it. It's worth in a certain age do PGDA because out of 7-8 embryos, only 1 or 2 statistically are genetically normal. And I cannot imagine wasting time, money, emotions on transferring 5 good-looking embryos which are genetically abnormal, okay? Because this could, you know, break your heart. And, you know, I'm also a human being. I'm taking this home, so I want to know what's going on. So these are the cases of people who are 40 years old with good AMH, with good response, that the strategy is freeze-all and PGDA test. And we have a chance statistically out of this, you know, many eggs have 1 to euploid embryos. When we go to the other, you know, side of 40 years old and AMH under 1, AMH under 1, maybe let's like talk about AMH and definition. AMH over 2 nanogram per milliliter. You have to look into this, guys, because in the UK, you guys use different units. You use picomoles. So this is what I talk about, nanogram. You have to multiply by 7.4, and then you have your units. So AMH more than 2, I expect it's a good ovarian reserve, okay? AMH between 1 and 2, it's something called diminished ovarian reserve. AMH less than 1 is low ovarian reserve. And then there are different shades of low. The shade of low 1-ish, between 0.8, 1.2. I still expect 7-8 eggs, 2-3 embryos, and statistically 1 should be good one, okay? So, but the protocol should be different. We cannot use, you know, 300 units or 250 units. We have to lower the dose of the medication, not to block this ovaries. So you still, with this AMH 1-ish, you have a chance to make things happen in your life at the age of 40. When we have somebody with AMH 0.3, 0.2, these are very difficult cycles. And, you know, I'm very glad that one of my colleagues said, Madam, you should be grateful that at the age of 42, you still have a blastocyst, okay? So with AMH 0.3, if I have 1 blastocyst in 1 cycle, and I have to give low dose protocol, then I would be keen on doing something called embryo banking. I cannot repeat back-to-back cycles. You cannot come here every month. You're flying in here every 2-3 months. So we let your body, you know, after egg retrieval recover. And I want to see out of this embryo banking at least 4 or 5 embryos. And let's hope through this hard work, we're going to find 1 genetically normal. The problem starts when we do a cycle and there is no embryos, means that the egg quality is so poor that no matter what we're going to do, I wouldn't feel comfortable allowing you embryo banking. If you are stubborn, you want to do it, I allow you to do it once, twice. And if in 2 cycles there is no embryos, we have to move on.
Okay, thank you. Dr. Harry, if there's something, you know, differences that you might want to describe, if you have any. So we're talking about, you know, sort of egg numbers you're expecting to see, you know, what's good, I mean, we know what's not good, but what's good, and the sort of success rates that you're likely to see with and without PGDA in women over 40.
Yeah, I mean, most of the things are already said. I mean, the numbers and the statistics are the ones that Natalia said. I mean, to have the statistics in your favor and on your side, you need to have in the age group of 40 to 42 about 15 to 20 eggs. Because if you analyze it, it's exactly like that. Out of these eggs, usually the statistics say that 1 or 2 blastocysts might be okay, or even 1. I have seen many things. I have seen women 42 to get 2 eggs, to leave them to blastocysts, to PGDA them, and to be normal. But okay, I mean, it's a matter of luck. It's a matter of how many are the chances and how many are the statistics and if these statistics are in your side or not. So I believe that in cases like that, the patient we need to be honest, and the patient needs to know in advance the difficulties. So for example, women with past polycystic ovaries that have very good AMHs, have very good antral follicular counts, even in the age of 42 to 44, we have seen it many times, they have achieved a chromosomically normal embryo. And the answer is that if you have a chromosomically normal embryo, euploid embryo, even if you are 44 or if you are 40 or 35, you have almost equal chances, almost, to get a pregnancy. So the whole point and the whole difficulty is to get this chromosomically normal embryo. And of course, if you have less eggs, it will be much more difficult. Now, if you go into a stimulation and you don't even reach the stage of a blastocyst, you understand there is a matter of quality. And as we have said from the beginning, there is no miraculous way of making the quality better. So in cases like that, you need to clerk the patient. You need to say that things are very difficult. Also, there is a difference between the 40 to 42 age group and the 42 to 44. I mean, it's quite steeper, the drop in the quality. And in ages more than 44, it is becoming almost, I mean, very rare. So it depends on many factors. The important thing is the patient to know in advance. And the decision is personal. The body of the woman is hers, okay? As far as you explain, I mean, I had patients that I said, listen, your chances are close to zero, and I advise egg donation. But they are not happy with egg donation, and they want to try it again. I mean, you are in a very difficult position over there if it really works that, because sometimes, you know, as doctors as well are feeling like, you know, getting money for chances close to 1%. But if you are honest, and if you, I mean, what else can you say? It is difficult, but the most important thing is to choose the right protocol, to clerk the patient, to explain everything. And it is happening. I mean, we have seen pregnancies even in the age of 45, but of course they are very rare. Yeah.
Okay, thank you. Dr. Nisa, do you want to add anything in terms of success rates? That's what we're talking about, success rates, numbers and pregnancies and live births.
Yes, it's always very difficult when we turn this into, but unfortunately, it's what we can give patients. It's what we can give you. It's what we can. It's based on that we can counsel you. So unfortunately, we have to regard on numbers and what numbers tell us. And we have been talking about the likelihood to achieve a good embryo, euploid embryo. But our main goal is to achieve a live birth. It's not a good embryo. Of course, if we have an euploid embryo, like my colleagues already told you, we have a very good chance of achieving a pregnancy. But even in that scenario, we sometimes don't achieve that pregnancy. So the most reliable numbers are really the live birth rate. And what we know based on studies, and that's all that studies, and we compare that with our own clinic success rate, and they are almost the same. What I could tell is that if you are around 40, I would say that live birth rate will be around 10 to 20%. But if you are 1 or 2 years old, 41 to 42, that success rate will decrease to less than 10%. And if we are talking about 42 to 43, then I would be saying around 4% live birth rate. And if you are 45, less than 1%. And those are the numbers, and we have to advise our couples based on that. Of course, it's like Harry told. Of course, I have in my lifetime, in my experience with my couples, some very good news, some things that happened that surprised me and surprised the couples, and I'm very glad when things turn that way. But unfortunately, I have the other 99% that didn't get those numbers. And like Dr. Natalia told, we are human beings. We deal with couples, we deal with emotions. And like I always tell couples, this is not a sprint, this is a marathon. And you have to really know where and when you waste your energy. And in my point of view, we need to really advise couples based on this ugly and sometimes very difficult numbers to put on table. But I think it's preferable to make a choice, a conscious choice based on this success rates than just believe that everything will just happen. So I think, like Dr. Harry said, we really need to see case to case, really analyze specific parameters, and based on that give conscious advice. But the numbers are these ones, and based on that, I always tell couples, of course, if you want to continue pursuing a chance to achieve a pregnancy with your own eggs, you have to prepare yourself for a long pathway. And that's why, and that's because we know that we will need a very large number of oocytes to achieve that good euploid embryo and at the end, a pregnancy, a live birth. But that's it. And we are always here to help couples and to try to give them all the opportunities to be comfortable with the choices they made.
Thank you. I was going to summarize some stuff, but actually you summarized it really nicely. For example, for the older woman, it's a marathon, but in a way, she doesn't have time on her side in terms of doing many more cycles. And then something that I think probably patients are sometimes wondering, I don't think clinics are lying when they say they've had success with ladies over 40, 42, 44. But what you have to understand is what Dr. Nisa told you, which is, your chances are maybe 4% or less. That's from walking into the clinic. If you have a blastocyst, it gets tested, it tests normal, and it gets transferred, your chances are quite high. They're approaching that of a much younger woman. But you have to have got to that tested blastocyst that tested normal. And that's where you lose all the numbers. So it's not that statistic is incorrect or false or somebody's lying to you, but you have to understand your statistics. You have to understand apples and apples. You have to be comparing the same thing. And that's really important. So we are running out of time, but I've seen quite a few questions about non-embryo factors, and Dr. Natalia mentioned them. We're not going to cover them today because we really don't have time and we'd only be scratching the surface. But I want to encourage you to come to, it's not the next one of these, it's the one after. It's the 5th of March. I think Caroline can probably put it in the chat for you. And it's about non-embryo factors, implantation factors, which includes endometrial testing. But I think perhaps if I'm hosting it, which I might be, we'll cover other things as well, because there's a lot of questions in the chat that are asking about, well, I had a PGTA tested embryo that was normal, but I still didn't get pregnant. So rightly, you're saying, well, what else is there? There must be something else. And we need to cover that in another session. But in the last 10 minutes that we have, we're going to go back to treatments, things that you can do, or things that we believe might have some impact and improvement on quality or quantity, particularly some of the newer treatments. I think we probably need to cover as well. I'll have Dr. Natalia do that about AMH, just this explanation of the different units. But first of all, I'm going to ask Dr. Harry in about 4 minutes to talk about PRP, please, and explain what it is and how that might help patients.
Yeah. Okay. First of all, PRP, to explain it as simple as I can, it means take blood, draw blood from the forearm, centrifugate it in a machine, and in the end, separating the plasma from the red cells. And with all this process, what we try to achieve actually is getting a sample that has an increased rate of growth factors, of cytosines. All these factors have a role in the follicular recruitment, in the follicular development. So the whole thinking behind rejuvenating ovaries, and the same thing is happening in the orthopedics, it's happening in the plastic surgery as well. The only difference is that here we take this sample that we have created and we inject it inside the ovary in a procedure that it is very similar with egg collection. And we give it time, and we measure the AMH and the FSH before and after. The whole process of follicular recruitment, of follicular development, it takes about 3 months. So, I mean, if the PRP has worked or not, it might take 3 to 6 months. To be honest with you, if it hasn't worked in 3-4 months, my personal experience is that it will not work. Now, if we have seen some advantages in all this process, PRP is the last resort try before you go to egg donation. If it is not working at all well with you and you want to try it, you can do it. We have kind of pioneered at IOLife in the IVF center where we usually cooperate in Athens, and we have many different PRPs as well. We have the potent PRP. We have a PRP that we centrifugate the blood in a very strong machine, and we get about 15 to 17 more growth hormones, which we call PL-PRP, because it actually breaks the platelets as well, so it increases more the percentage of the growth factors. And we even do stem cells, which means that we take adipose tissue, fat tissue from the tummy. We analyze it. It takes about 1 month, and all the sample has stem cells actually. And what the previous PRP was doing was to stimulate the stem cells to produce these growth factors. I mean, when you take the stem cells, you just inject the stem cells inside. So there are many different variations, many different things. I need to clarify that none of these things, to my experience, even though we are trying them for long time, I cannot really say that it is associated clearly with an increase in pregnancy rates. But I can tell you that especially in women that are less than 40 years old, we have seen significant changes, not in all the women, but in many women, and especially younger ones with low ovarian reserve, in the follicular recruitment, in the number of eggs that we can get. In a way, as we said before, the more eggs you get, the more you increase the chances. I cannot clearly associate it with improvement in quality, even though there are some studies about that as well. I cannot clearly associate it with improvement in pregnancy rates, but if you are a very poor ovarian reserve, and especially in ages like 40, 42, or 40 and younger, it is something that you could try before your IVF to see if there is any improvement. So if a cycle hasn't gone well and you don't want to jump to the egg donation or anything like that, it is something that it will not cause you harm, and it might help getting you some more eggs.
Okay. Thank you very much. Sorry to stop you there, but that's great. Dr. Nisa, 2 minutes. Sorry, we are running out of time. 2 minutes. Can you talk about very briefly, if you've got a patient in front of you, they're over 40, that you can't do everything. So in what order are you going to do things, supplements, PRP, whatever? What's it? I was very grateful to Dr. Harry for saying PRP is our last resort before egg donation. Well, that's really clear. That's really clear. So what's your pathway for things to improve quantity or quality in eggs?
Okay, first of all, we would need to study that couple, to do a clinical history, a more detailed one, to get the more information we can get, because we are focusing now on egg, but we have all the other part, the male part, so we need to cover that also. But let's just focus on quality and quantity of the egg. Of course, again, we need to check the ovarian reserve, and based on that, based on age, based on also the weight of that women, we will then decide which protocol we would use. Of course, if that couple already have done any other cycles, we have to study them and to understand what we could use to improve. Because, for example, if that couple already had other cycles with very asynchrony cycles in follicle growth, we could use some pre-treatments, for example, with estradiol or other pre-treatments that we already discussed. And then define a specific protocol for that lady. Of course, if we are talking about over 40, we are most of scenarios not expecting that much reserve, that much response. So very often I advise these couples to think about egg accumulation, and that is here something that we usually perform when we have women with low ovarian reserve, is to try one cycle into the follicle phase, and then based on the result, 5 to 6 days later, try another phase and then accumulate more oocytes. And when we achieve the number of oocytes that we are comfortable with, then we perform the fertilization. We wait until the blastocyst stage and we perform PGTA. I think this is mainly our first step that we will go into, of course, based on results. Then we will, like Dr. Harry already told, first simple, and then just be specific with each couple what we could do next. Of course, new technologies like PRP, we would only advise in certain kind of situations. It's the last resort, because like Dr. Harry also told, we don't have much information, we don't have much studies yet, so much has to be done first that we can counsel and advise these new technologies to everybody. But I think that it's the main things that we would perform. And of course, then just understand how many good quality blastocysts we achieved, how many of those were genetically normal, and based on the results, then a different stage will be how we will transfer those embryos, which protocol we will transfer, what tests we would perform first of performing a transfer. So that's another check.
Yeah, we'll leave that till another day. Thank you very much. I'm just going to go to Dr. Natalia for the last thing. I'm choosing this question, but actually the questions are generally around this kind of counterintuitive thing that I think all of you mentioned, but I think you mentioned it the most, which is you don't necessarily increase the dose for an older lady for different reasons, or at least not for all of them. And I think that's probably, if you can give a simple answer for that, and then just remind everybody that in different countries, you need to look at the units of that the AMH is measured in, because they're different. And so, yeah, that would be helpful. Thank you.
Okay, so when somebody's coming here for the last treatment, we have to review what has happened to you before, what kind of cycles you had before, and what can we do differently. And if we review your story, and if we see that you were successful with this medication, because some people respond better to this brand than to the other, we're definitely going to repeat the brand that you had one blastocyst, in your country. You can imagine that I'm coming from, doctor's family. I'm third generation gynecologist. So if you were to talk to my mom, okay, conservative German school of gynecology, nothing frozen, everything has to be transferred fresh. So then you do not give high dose of medication, because you are afraid of hyperstimulate. You are afraid of making your, endometrium not receptive. And this is the moment that you give a patient, the lower dose of medication, like 150 units of recombined FSH-LH. When you talk to generation of, of people like me, who graduated medical school in the 90s, early 2000, starting working gynecology. I'm a school of Professor Bruce Shapiro, means freeze all, transfer all, test all genetically. So, as what Harry said, we have sometimes, ladies with polycystic ovary syndrome at the age of 42, and I have 20 eggs. Amazing. But in order, to have this 20 eggs, I have to get them from something. I have to see your inclusion criteria to IVF cycle. I have to see your AMH to allow myself for this middle or higher dose, of medication. So I'm glad that, you know, Nisa and Harry, they are focusing more their treatments on antral follicle count. No, American medicine is more about AMH, because then, you know, insurance companies pay for this amount of medication and not anymore. So we adjust a dose to patient AMH. And as I say, we have to see what we are heading into. What is the goal? If we want to transfer fresh, have to give you low dose of medication to, you know, to have estradiol units at the day of triggering, not more than 2,000. So if I give you high dose of medication, there's no way in the world we can achieve it, okay? So this is how we adjust a dose of medication to different AMH, and we do it age independently, and we have to see, and we have to be clear about a goal. If we transfer fresh, because you know, some people do not believe in PGDA, or we want to know if the embryo is genetically normal or not, and then AMH. So wow. There are different units that we have to be very careful with. In European Union, majority of AMH, anti-Müllerian hormone, are expressed with nanogram per milliliter. There are totally different units than the UK ones. And the UK units, in order to have a UK unit, you have to multiply the nanogram through 7.4 to have a UK unit. And then, you know, you guys have different numbers for good, diminished, and low ovarian reserve, okay? So this is something that, you know, we doctors, we have to be careful with when we get patients from abroad. When I see that somebody has AMH 68, I know it's a UK patient, okay? Because there's no way in the world that somebody in European Union will have this this amount. So yeah, do not overdose the medication, because as Harry said, there's a certain moment in your life that no matter how much medication you're going to give, the AMH 1-ish, which is UK 7, is not going to respond. So don't waste your time, energy for this kind of cycles.
Okay, thank you, Dr. Natalia. That's really great. We did have lots more questions, but we are out of time as far as I know. Thank you for all attending and engaging so well. And I am sorry for those of you who've given very, very specific questions, but I do think, you know, about your particular cases, I do think they're probably best going directly to the doctors or the clinics. And the reason I say that is because you've given a lot of information and it was hard for us to read that in time, but also there's probably a lot more to it. And I don't want us to give a kind of superficial answer to what is obviously a complex question. So I don't think that's fair to you. So sorry if your question wasn't answered tonight. I do hope it's been useful though. I'm just checking with the host. Oh yeah, okay. So thank you for all coming. Thank you to our panelists. If it's been useful for you, please let us know, because feedback is good. If there are topics that you want us to discuss in the future and have these kind of Q&As or even webinars, then please let us know. So put that in the chat or contact Caroline separately. I think our next one of these Q&A sessions, or at least the one I'm going to be doing, I think is specifically about PRP, one of the things you've heard about tonight. And that's on the 20th of February. And then I think on the 5th of March, we're looking at doing one on those non-embryo factors, so implantation factors like endometrial factors. So I'm sure that will be super interesting. So thank you all very much. Hope it's been really useful, and hope to see you all